Hi, it's Tom from Running Physio here. Today I wanted to come to you with a slightly different type of video on a discussion point that's been really popular in running repairs online, and that's to discuss all about diagnoses and running injury, whether it's important, whether we can diagnose, whether it affects treatment, but also potentially the downside of diagnosis and overdiagnosis. So for this, as I said, is more of a discussion point. I'd really love to hear from you. What are your thoughts on this? Do you think that we need a diagnosis to guide treatment? Do you feel sometimes the diagnosis leads to problems? Do you feel we overdiagnose issues, particularly in running injuries? Have you seen any cases where it's caused problems? So really welcome you to say what your thoughts are on this in the comments and replies. Let us know what you think about it, and you can share any research and resources you think might be relevant. The idea here is to share our knowledge together. So as ever, we've got the link as well in the title to our running resources page. So we've got a great collection of free webinars there. The lateral hip pain one's been especially popular at the moment. So if you want some more free content, click the link and go and visit that. So let's start with the first question here in this discussion. How important is it to diagnose when we're working with a runner with an injury? Well, I think for the runners, they often feel that a diagnosis is really quite important. And actually, sometimes they'll specifically say to you, well, I just really want to know what the problem is. So if it is important to them, I think it should be important to us too, to try and help them find out what this problem is. It can also be reassuring for them to know what it isn't. So if we're able to tell them, yes, it's this issue, but it's very treatable, we've got a plan, we can work together, we can help things improve, then that can be very reassuring for them. And I think sometimes it can feel as a therapist as if we're working slightly blind if we've not got some kind of working diagnosis, some kind of idea of the problem that we're treating. So I think it can be important to reach a diagnosis, but it's also important that we explain that to the patient in the right way so that they understand it. It isn't just a question of putting a label on it, we've got to explain it to the patient. And that's actually where I think another feature of forming a diagnosis can be useful, in that it can connect the dots for a runner to help them see the connection between perhaps how they've trained, how certain tissues become sensitive, and then what they can do about it. Now, an example we'll use through this video is a runner that came to me with what turned out to be proximal hamstring tendinopathy. Now, when we look back through his training, you could see that there was a real rapid increase in hill running. And we know hill running increases the stress on the proximal hamstring tendon. So we were able to connect those dots together to say, okay, well, this is how you've trained, and this would increase the stress on this region. This region's now become sensitive and sore, and it makes sense that that would be the issue. And here's what we're going to do about it. We're going to reduce your hill training, we're going to strengthen up the hamstring, etc., etc. So a useful way of forming that diagnosis, connecting the dots and helping it make sense with the patient. The next question is, can we actually form a diagnosis for people presenting with running injuries? Now, in other areas like non-specific low back pain, it's estimated that we can't form a structural diagnosis in around 85% of cases. And I think what's come from that is we've become a bit more comfortable working without a diagnosis and working to general principles. And I think that's fine in some areas. But I do think some running injuries lend themselves more easily to a diagnosis because the pain responds a bit more predictably with load. Many runners I see, they only have pain running or only have pain with very specific activities of daily living. And also the pain tends to be more well localized, which again makes it easier for us to approximate what the issue is. So I feel much more confident reaching a diagnosis in a runner with Achilles tendinopathy than I would say with someone presenting with non-specific low back pain, trying to label it as something like L4-5 facet joint dysfunction, which I just don't feel we're able to do. So yes, I do feel in many cases, if we take the right approach, we can at least form a working diagnosis with running injury that can help us as we go forward. So that leads to the next question. Well, maybe if you can work out a diagnosis, does it actually affect treatment? Does it matter? And the argument in non-specific low back pain is no, it doesn't. It's not going to change the treatment a great deal. But I would argue that in running injury, it may well change the treatment. Now let's come back to that runner we talked about at the start with proximal hamstring tendinopathy. Now, when they were seen elsewhere, it was misdiagnosed as neural pain coming from the lumbar spine. So all the treatment was directed towards the lumbar spine. Lots of stretching of the lower back, neural glide exercises to improve the neural component to it. So these were actually quite provocative for the hamstring symptoms. So that actually there wasn't really anything directed towards strengthening up the hamstring or changing the training or really addressing the more specific diagnosis that we were able to reach later down the line. So actually, as you can see in this example, and I'm sure you will have examples in clinic too that I'd be really interested to hear about, sometimes the diagnosis does actually affect the treatment. So it can be important to try and be a little bit more specific about what you feel the source of symptoms are. Now, we've all worked with patients where we can't really form a working diagnosis. Perhaps they've got very irritable symptoms, so lots of things that we're testing are coming back positive. There's diffuse pain, it's perhaps a bit unpredictable, it's not easy to work out what the problem is. And I think then over time it becomes clearer. So I'll often tell a patient that as we work together, the problem will become clearer and we'll be able to form more and more of a plan together. Now, in that situation, if you can't rule something in and form a diagnosis, we want to see, can we rule things out? Can we narrow the options down where possible? And particularly in running injury, one of the diagnoses that we would like to try and rule out where possible is a stress fracture, specifically a high-risk stress fracture. Now, on average, these take around 3 months to diagnose, according to the research, so they are often missed. And this can be one of maybe the downsides of being happy to work without a diagnosis, as it may mean that you're going to miss certain serious pathology that needs different management. And this is the case with high-risk stress fractures. Things like femoral neck stress fractures can progress to a fractured neck of femur. So the current evidence suggests they do actually need urgent MRI, urgent X-ray as well, to make sure there's not a true fracture there. So if you can't rule things in, do try where possible to ask the right questions to rule things out. So with stress fractures, we'll be looking for whether they're getting pain with walking and weight bearing. If they have risk factors for a stress fracture, perhaps they've had a previous history of stress fracture, or they're underweight, or they're systemically unwell. We're looking for those signs and symptoms and knowing when actually we need to take the next step and when imaging things is going to be appropriate. So I think there are some things there, some positives of reaching a diagnosis, but I do think it is important how we discuss it with someone. Something that often happens once you put a label on a problem is that the patient then goes off and Googles it. They ask Dr. Google, and unfortunately, when you search for things on Google, you only get the worst case scenarios. People don't take to the internet to tell you about how wonderful their hip pain was and how quickly it got better. They tend to write about how awful it was and how it's taken over their life. So I would encourage you to say to people, don't Google this. Any questions you have, any concerns, come to me. That's what we're here for, and we can give them some more specific advice and ideas. So far I've been fairly pro-diagnosis, I think. So now we need to look at the other side of the coin. What are the potential problems with forming a diagnosis or a diagnostic label? And there are actually some. There's things like tunnel vision that we need to be aware of. Now, this happens when we reach a diagnosis and we treat a diagnosis. We stop treating the person. We sort of go into recipe mode a little bit, because it's almost easier for us cognitively to say, okay, this is patellofemoral pain. What I do for patellofemoral pain is X, Y, and Z. But that's not how we should be approaching it. Of course, it needs to be specific to the individual. And sometimes we can end up just being focused on that diagnosis and following a very familiar path to that without being able to see whether the patient's actually achieving their goals, whether they're actually improving, and whether they do actually need a different approach. So do be aware of tunnel vision that happens with diagnosis. Do be prepared to review your diagnosis if things are no longer fitting. Now, I know that can be hard, because sometimes it can mean talking to patients saying, maybe we didn't get this right initially, but that's important to do if it means a better standard of care for your patients. Now, there is a bit of a balancing act with diagnosis and overdiagnosis. We've talked recently about patients having unmet needs. They're not really getting the support and the guidance that they want. But there's a balance between unmet needs and unnecessary care, over-treating, over-testing, describing things as pathology when they needn't be. And that is something we need to be very aware of. Now, there's a great paper on this from Mayer et al. That came out in 2019, and I've done this graphic to summarize what they've talked about here. Now, they talk about this problem of overdiagnosis leading to a number of different issues and overuse of healthcare. So, overdiagnosis can lead to overtesting, to overdetection, to overdefinition, where we start to define things that are essentially normal as a pathology, and then on to overtreatment. And this then can lead to overuse of healthcare and an increase in treatment burden for individuals. And I think this treatment burden phrase is quite an important one, because we need to recognise that when we're working with patients, the solutions we give sometimes can actually feel like a great big long to-do list for the patient. So we need to be aware of the burden of treatment and try and lessen it wherever possible. Exercise prescription is a good example of this. Giving someone 20 exercises to do might feel like you're offering solutions, but to the patient it's often a bit overwhelming and a bit unrealistic. Now, if we have a look at this here, let's come back to our patient with proximal hamstring tendinopathy. And we go through these 4 problems here. So, over-testing. Well, initially it was felt he had neural pain coming from the lumbar spine. So he was then sent for an MRI, although there were no features there that really would indicate it. There were no changes in neurological function. He was systemically well. He had no past medical history. So he was sent for an MRI, and we can see this as over-testing. This led to over-detection because the MRI identified a small disc bulge, which we know are present in many people. So this was then considered to be the cause of his symptoms, and this is a problem with over-definition, where we see something that may well be normal, like a disc bulge, and we decide that's the problem. And then that led to over-treatment. In this gentleman's case, a spinal injection that was ineffective in changing his pain and very costly for him financially. So a big treatment burden in terms of that. So we can see here that this overdiagnosis can actually sometimes lead to a whole range of different issues that we need to be aware of. And I think maybe myself personally, I would reflect, what elements of over-testing are there in running injury? Is gait analysis maybe sometimes a bit guilty of over-testing? We're strapping someone to an expensive 3D machine and loads of technology. Are we likely to over-detect there, collect a whole range of data that may not be relevant? And then our over-definition, we start to look at that data and assume it's relevant to injury and make a whole host of changes which could well be seen as over-treatment. So, some food for thought there in terms of the balancing act between those unmet needs and referring off for unnecessary imaging, unnecessary treatment and unnecessary care. And I think there is a bit of a balancing act that we need to achieve here, and it starts with careful communication with the patient to help them understand, if you have formed a diagnosis, to help them understand that diagnosis and explain it in a way that helps them to manage it. Also to work collaboratively with the patients to help them make choices about their ongoing care, about investigations, about treatment options, about what they want to do. Because if they know that a scan isn't actually going to be helpful for them, then hopefully they can make that choice with you about not going down that path. We also need to be aware that not everything needs treatment, and not everything needs a lot of treatment. Natural history can be very effective in many cases, so we do need to allow things enough time and be prepared sometimes just to put a couple of things in place to help things improve. In runners, I would say in many cases, if you can bring the training to the right level so it's no longer irritating tissues, that will be enough. So we may not need to go down the route of extensive strength and conditioning programs or gait analysis and retraining. And that's sometimes a good outcome, just being prepared to do a bit less. And then the final point here is, do be aware of the benefits of our treatments, but be aware too of the harms that are potentially there with our treatments and assessments. We tend to under-recognize the negatives of what we do. So if we start to recognize there are sometimes negatives of sending people off for more investigations, more expensive treatments, things that they don't need, perhaps we're going to be a little bit more sensible about the selections we make with the patient in terms of their treatment. So I'm looking forward to reading your comments and questions. I can see a good friend of mine, David Poulter's already commented here. So let's just see what David said. So he said, best guess and offer a good explanation and hence prognosis. I think prognosis is as important as diagnostic label. Cans, can't, when and why. Yeah, people that watch the videos regularly will know I really like David's view on things, and I think this is very sensible here. You know, using some kind of diagnostic label, but also talking about the explanation and prognosis. So he goes on to say here, I'm treating this unique individual with X, Y, and Z versus I'm treating X, Y, and Z. And I think that's a really good way of looking at it. You know, it always is going to come back to treating the individual as opposed to treating the diagnosis. And I think that is something we need to be aware of. So thank you, David, for commenting. And I look forward to reading anything else that people put up there. Do post questions if you want to. As I said, there is that link to our webinar series if you'd like to find out more information about Achilles tendinopathy, lateral hip pain, or low back pain in athletes. Okay, thank you very much for listening. I look forward to reading your replies and comments. Bye for now.